what I'd like to do is just review the science of ultrasound. This is a recap of what we learned in Visualization Part 1. Ulthera is a system that harnesses the power of ultrasound, both in the visualization and the therapeutic ultrasound. The visualization allows us to treat at certain depths to make sure that we are creating those little thermal coagulation points in the appropriate tissue. As you know, ultrasound requires a rich substance to propagate the waves. So we use ultrasound gel. We want to make sure we have good contact with the epidermis. And we want to make sure that we have a good, stable contact to the tissue when we have the transducer sitting on the skin. Once we activate the transducer into ready mode, it results in an echo image that will travel through the epidermis down to our different layers of the tissue and give us, or propagate back and give us a visualization on our Ulthera screen. As you know, because all of you own an Ulthera machine, we generate the waves using the transducer with the handpiece. The ultrasound emits a columnized sound wave that will actually propagate through the epidermis, and as it hits different tissue densities, it will actually give us an image back on the screen. And really, that is the key, that is the most important part, which makes me excited when I'm doing treatments with Ulthera, to be able to visualize everything such as platysmal bands, muscle, bone, areas that we don't want to treat, but we do want to treat subcutaneous tissue, the SMAS, that cutaneous tissue, and the epidermis. Okay. So reviewing, I'm going to go with my pointer here, reviewing the science of the ultrasound. We have the transducer. We use the coupling gel or the ultrasound gel to create a good contact with the epidermis. That's key. We don't want it too thick. We just wanted a very thin layer to allow us to get a good visualization. We want to make sure that we don't have any ghosting or gaps in the ultrasound image from top to bottom of the screen, and it's uniform from left to right. As we activate the imaging or the scanning, the ultrasound will propagate through the tissue, and as it hits the different density of the tissue, it will actually give us that image back. So with the different tissue types, it varies in density, and we need to know where we are sitting to understand the anatomy so that we know the areas that we can treat or cannot treat. By using our visualization, we can identify if the 4.5, for example, in the mid-medial cheek, or the 3.0 is appropriate, or if the 1.5. When it comes to the brow, we're going to always make sure that we see the bone or the frontalis muscle well below our treatment line, and we'll use a 3.0, a 7.45 on somebody who's got a thicker brow, and a 1.5. So the reflective waves that echo and travel back through the transducer gives us that image on the screen. I can't stress enough how important the image on the screen is when we're treating the entire face, chest, neck, or the décolleté. But more importantly, it's very important that we use the visualization and we are very precise in our positioning. As you know, we've got different properties of the ultrasound. It's hyperchogenic, which reflects and scatters the ultrasound waves, resulting in a bright image. We've got hypochogenic, which reflects and scatters the ultrasound waves poorly, resulting in a dim image. Or we've got anachogenic, which does not reflect or scatter. We want to make sure that we have a very precise image. As you may or may not know, you can adjust the brightness of your ultrasound image. Sometimes when we're working in an area that in a clinic that other technologies are being utilized, it may interfere a little bit with our image, and sometimes by changing our image brightness or lowering the brightness will make a difference in our visualization. The scattered and reflected waves appear in areas varying brightness depending on the density of the tissue. For example, if we're working in subcutaneous tissue and we've got a thick someone with larger cheek areas, we'll actually see a lot more darkness with the scattering of that white ultrasound image. If we're working on the brow, we're going to see a very, what we want to see is that frontalis muscle or the brow bone or the periorbital bone, very bright, distinct line. Because it's a lot denser, we're going to see that thick line. And as I go through the presentation today, we'll show you different images of what that looks like. Okay? We don't have any. So to review this slide here, I'm going to hopefully be on the screen with the slide. The epidermis and the dermis. We see the thickness of the epidermis in the top 1 millimeter to 1.5 to 2 millimeters. And you'll see that it's a lot denser. When you get a little bit lower in that 1.5, 2.0 to 3.0, that's when we start getting into that subcutaneous fat and fiber septi. And then as we get a little bit lower than that, we may start seeing things like the bone, okay? When we're dealing with the brow area, we want to make sure that we're always working just above the frontalis muscle or the bone, and we see that image from left to right, okay? And we want to make sure that we have a good contact with no ghosting at all. Let's review the anatomy. The anatomy is the most important part when we're treating the upper face. We need to understand exactly where we're treating, but also the positioning of the transducer, that we have the hose to the nose. When we have our models on the table, we'll revisit that again, and that we're always working away from the orbital, the eye area. So the hose is always moving away from the eye, and we always see the brow, the frontalis muscle or the bone on our screen from left to right. And I'll review that again when I've got the machine in front of me. When we look at the frontalis, and I hope you guys see this here, or that we're treating the brow area, we are not treating the frontalis whatsoever. We want to make sure that we are working directly over the orbital rim. And the reason why this is important is, I'm going to go to our next slide, is our nerves. We have the supraorbital nerves and we have the temporal nerves. We have a number of nerve fibers that are positioned throughout our anatomy in our face and around our lateral sides of our face that we want to make sure that we're not treating. That makes the difference between a comfortable treatment and a not so comfortable treatment. We want to make sure that we're treating the right tissue, and that again is right over that orbital rim. Because visualization is important, one of the big downsides is that we can't see the nerve fibers. So I can't stress enough how important it is for us to all really take our anatomy book out, or even going on to an application on your phone, on your iPhone, or whatever it is that you're working with, and understand the different nerve fibers and bundles that are positioned in our areas of treatment. I went to Anatomy app and I was able to pull this image up. And I drew in, you can see here, I marked off the supraorbital nerve. That's that notch that we put that little X or that V on. And then our treatment lines that we use with our treatment guideline, our ruler, and mapping out our treatment zone. And you'll see that the yellow is the area where those nerve fibers in this anatomy app, you can see that coming up. And that anatomy or that nerve fiber will come up and hover and traverse over that frontalis muscle. So if we're working up too high with our transducer, I can guarantee you that you are going to hit that nerve, and it's going to be a very uncomfortable treatment line for that patient. So again, really look at your anatomy, understand different branches that are positioned on the forehead and around the eye. The temporal branch is another area that when we're treating those crow's feet or that lateral part of our eye, that we may or may not it may or may not come in our treatment zone. So we want to map out so that, and I'll show you on our first model, that we want to work around the orbital rim. We draw our line, and then we make our lateral lines from the outer area of the eye towards the hairline. We don't want to work near the hairline. We want to work, again, around that orbital rim. I can't stress that enough. That's really how we make our treatment in the brow area comfortable, and the patients get through it without any kind of nerve ending sensations. Okay? The next slide is really understanding and looking at our patients. As you know, our patients will come in all different shapes and sizes. We have different ethnicity. We've got male and female. We've got people that have very short brows, very short foreheads. They may have the longer forehead, or that gentleman that may come in that has the never-ending forehead. We want to make sure that we map out around the orbital rim. Some people have a different amount of density or thickness or subcutaneous fat. So that will affect our treatment as well. Typically, if a gentleman comes in and he's got a very heavy brow, that's when we're definitely going to be using our 7-4-5. Then we'll use our 3.0. But on average, most of our women that come in, we will treat them with the 7-3.0 and the 10-1.5. If we look at these three models here, you can see we've got a 40-year-old, a 43-year-old, and a 54-year-old. They have all variations of BMI or structure, and you can see with the visualization in this first client that her frontalis muscle, or the frontalis bone, is really sitting just above that 4.5. So we could probably get away on the upper brow with the 7-4-5 and the 3.0 protocol. If I look at the next client, you'll see that the frontalis muscle is really sitting at that 3.0. And this is where I would actually definitely work with my 7-3.0 or my green transducer and my 1.5. If my treatment line is sitting directly on that bone, what I'll also do is alleviate or reduce the amount of pressure that I have on the patient's skin, on the epidermis, to give it a little bit more of that gap. If your client doesn't have any Xeomin in, sometimes just by getting them to raise their eyebrows up, it will actually give you a little bit more distance between the frontalis muscle and the subcutaneous tissue to treat in that good area, in that correct area that we're trying to cause those little TCPs. I hope that makes sense. If anybody has any questions, by all means, send me a message. The next client, she's Caucasian, and you can see that she's hovering at that 4.5, but a little bit up into the 3.0. This is where at times we may have to shorten our treatment line. If we can't get from left to right on our screen the entire orbital or the frontalis muscle, or we're touching a nerve because that patient feels that sparky sensation, or it travels a little bit, then we may want to shorten our treatment line. And I will go through that when we have the patient on the table and we're actually in treatment. Okay? So let's look at this first client. So I'm going to ask you, if you're sitting in your team with your team, have a look at this and have a discussion about how you would treat this particular patient. How I would approach this is I would definitely start with my 3.0, and I would go from medial, and I would always work from medial to lateral, and I would do full protocol with her, and then I would change my transducer and do the 10-1.5. We have more than enough room to treat her with the 3.0, and we could possibly do the 7-4-5, but I think if we go a little bit lateral here on the screen, we'll be definitely touching the 3.0. the bone or the bone or the frontalis muscle. I hope that makes sense. If we look at the same patient, a reminder on that medial cheek, we're going to have a lot more density, a lot more volume, so that we will be able to treat with the 4.5 and the 3.0 and the 1.5. It's the brow. The brow will always be a little bit of that, when we first start out, it makes us a little nervous, but if we really focus on visualization and taking our time, we don't need to rush this. We want to make sure that we've got the hose to the toes or hose to the nose, and we're working with the patient to actually lift her brow up. We can make it very comfortable. The next slide is a gentleman. And as you can see with this image, we have a lot more density or thickness of the epidermis right to that frontalis muscle. So, how would we treat this patient? I would have absolutely no concerns at all by pulling out my 7-4-5 and doing that protocol on him, and then the 3.0. He may, if he does have, this patient, it's hard to see on this image, if he had a little bit more of that laxity or crepey skin on the surface or surface wrinkles, I would definitely treat him with the 1.5. So I would try to get 3 levels of treatment, if not 2, and I may double up on the 3.0. When a man comes in or someone who has a very heavy brow, we need to work a little bit harder to get that 2 millimeter lift. When I look at the results that we've seen in some of the clinical studies, but also in clinic, when women come in and they complain that they've got that hooding or that little bit of heaviness, or they're not candidates for a neurotoxin Xeomin, then by all means, this is my first discussion that I would have with the client, is getting that natural lift with the Ulthera. A reminder, Ulthera was first approved. The first approval was the brow. This next slide is how this particular client is, I think she's that 43-year-old, and you can see by this image that she doesn't have as much thickness or density in her brow area. So she's hovering just above that 4.5. We could do the test with the 7.45 and getting her to raise her eyebrows up to see if we can create a little bit more distance between the frontalis muscle and the and our treatment line. Otherwise, I would definitely just go right to the 3.0 and the 1.5. So I just had a question that came in, and the question is, do you suggest to add more lines with either the 7.30 or the 10-1.5 when you can't treat with the 4.5? That's a great question. I will always give my clients more. When we look at the protocol with the 4.5, the 7.45 or the 7.30, it's 25 lines and then 25 lines. I will always do double of everything. It's only 50 more treatment lines. And I know that if I can deliver a total of 75 treatment lines in one brow and 75 in the other eye or other brow area, I know I'm going to get an exceptional result. Anybody over the age of 40 or 45 that has been doing Xeomin for the last several years, or they naturally have that hooding, I will always go immediately and double up my treatment lines. It's not going to take you much longer, but it's definitely going to make sure that that client gets exceptional results. I hope that answered your question. So going back just to recap with this particular client, definitely with the 3.0, I would treat her 2 levels or twice. So I would do 50 lines with the 3.0 and then I would do the 1.5. I definitely try to get that 2 layers of treatment at all times because it creates that contraction. Those TCPs, if we can do it, remember, Ulthera is the foundation. So if I can treat with the 3.0 and the 1.5, my results are going to be even that better. we're dumping collagen into the skin, we're dumping elastin, we're trying to create that as much of a lift as possible. And when we want to get that 2 millimeter lift, or that, based on the studies that were done, the more is better. Okay, so let's go to our next client. So this particular client has a very short brow compared to our last two. When I look at her, I see that we're a little bit between the 4.5 and the 3.0. She does have a little bit more density in her subcutaneous tissue. She is a little bit younger. I'm still going to actually treat her with the 3.0, and I'll do double the amount of treatment lines, and then I will do the 1.5. If for some reason you don't want to do the 1.5, or you choose not to use the 1.5, I would definitely do at least 3 times the 25 treatment lines. This is kind of my protocol that I've done. You do the minimum of two passes, so 50, but if they are a little bit more hooded, or if they're a little bit heavier, I would definitely use another 20 to 25 lines in that area. If we look at her medial cheek, she does have a lot more thickness. So to me, when you look at a cost factor, if we're treating, for a full brow lift, a full periorbital, even lower, we're going to be charging anywhere between $1,500, $100. Clinics in Canada are anywhere between $1,000 to $1,500 for the brow lift. When you're delivering 150 to 200 lines or 250 lines, your profitability is still quite substantial. So more is better, get better results. It costs you a little bit more, but your return on investment is still very great. All right, so let's go to the next image. So this particular client, she has a little bit of different anatomy, and you can see that we're definitely at the 4.5. We could probably treat her with the 4.5 to a certain point, but then the way her periorbital rim sits, it actually starts going up. I call it the peanut. When we do that, docking that ship into our treatment zone, and I'm sure most of you know that if you've trained with me, I kind of use that analogy. You'll actually see the frontalis muscle, or the bone, and then all of a sudden it'll go up like a peanut. Once that is going up, you're now going into the frontalis, and we don't want to treat up there. We definitely want to treat directly over the periorbital area. So if you find you can't get, you're getting into that frontalis muscle right in this area here, then shorten your treatment line. Shorten your treatment line so that you're treating from this point back, and you're not going to run into any of those little nerve sensations or hitting any of that supraorbital or that temporal nerve that kind of goes across our frontalis muscle. That's the difference between a comfortable treatment and a not so comfortable treatment. I can't stress enough the importance of really understanding that anatomy. Don't forget to ask that patient to also lift their brow. The more they lift their brow, the more space you're going to get between that frontalis muscle and the subcutaneous tissue to drop your treatment lines, your TCPs, so that it's more comfortable, and all they feel is that little bit of that heat spiciness. Okay. We have Ernie here, and we are very fortunate to be able to work with Ernie. He's given himself up to science. All right. So what I want to do first is, Ernie, can you just lift your head up a little bit?
How far?
Just like that. You can see that Ernie has a little bit more of a heavier frontalis area, and a little bit, it can be deceiving. Can you look angry for me? Yeah, there you go, and lift up. And you can see with a lot of Asian patients, they have that natural hooding. You can put your head back down. That's your workout for the morning. Mm-hmm. A lot of Asian patients want to get that lift. They don't like the fact that they have that hooding. So I will automatically triple up my protocol when working on the brow area. So first of all, I'm going to start with my ruler, my marking ruler, And I am going to, my fingers are cold, Ernie, I'm very sorry.
Okay.
I'm going to just kind of palpate around the periorbital to get a sense of his anatomy. Once I do that, I will actually take my marking pencil and I will draw my circle, my semicircle or my C, just over the bone area. Okay, always making sure I'm on the ostium. At this point, I am going to get Ernie to give me a big smile, and he's got crow's feet. Wow, I'm just kidding. I am actually going to take my ruler and I'm going to make right from the corner of his eye, I'm going to make that straight line down. Okay?
Can I continue to smile?
No, you're good. You can be unhappy now. And then if you go back to your treatment guidebook, we're going to count 5 lines down, or we're going to do one full from a black line to a black line, or you can actually count the 5 little dots. I'm going to make my dot, and then I'm going to draw my line, and I'm going to do the same from that mid-canthus area. I'm going to count 5 lines, and on an angle, I've created my treatment area for the the lateral part of his eye. Now, when we're treating a lot of women and men who are prone to festoons or that laxity where they get those larger bags under their eyes, I will always palpate the orbital rim and I will make my line just like so that I know that when I do my treatment, I'm going to start at the orbital rim, the bone area, and go straight down. And I will demonstrate that as well. We're going to palpate for the supraorbital notch. And sometimes if you have a hard time finding it, I'm going to get you to look angry, Ernie. When he looks angry, I can actually feel it better on him and then relax than on when he's not looking angry, because the muscles are just pulling out of the way. I'm going to get you, Ernie, now to look up at the ceiling. I'm going to go mid-pupil, again, making sure that I'm marking on top of the bone, mid-pupil, and I'm going to make a line just over that orbital rim. One of the biggest mistakes that I find, and again, I was doing this at the beginning as well, is we were drawing our line all the way up to the hairline. When you do that, we naturally get into our position to do the treatment, and we find ourselves sliding up into the frontalis and moving away from the orbital rim. So what I would recommend is always just make your treatment line from that mid-pupil no more than 2 bars, okay? So I'm going to just wipe that. So no more than 2 bars, because this is the area that we are going to work. So at this point, I count off the 10. Over the orbital rim again. I hope you guys can see this okay. We've got a great camera crew here today. So now, and Ernie, I'm going to get you in a second to just lift your head up and hold it for me. And you can see now my treatment area is literally going to be between here and here over his orbital rim. If I draw that line straight up, we have the tendency to slide up a little bit more. Okay. All right. So I'm going to get you to turn a little bit more again here. I'm going to just draw this out just so I can demonstrate. Count out my 5 lines. You know, for those who are starting with Ultherapy, don't be afraid to position the treatment guide when you're mapping and marking out your patient. You know, when I started, I did the same thing. I would have the patient hold the guide, and I would actually read it and remind myself how to do the marking. Once you've practiced this, don't be afraid to practice this on friends and family at the clinic. But once you've practiced this a few times, it comes very naturally and you'll never forget. I actually think I mark people in my sleep. Perfect. Yes, I have no life. So I'm going to get you to squish your eyes shut again for me, Ernie. Get a feel for that supraorbital notch. Perfect, relax. I'm going to map it out. I'm going to get you to look to the ceiling. Ernie, I promise this won't hurt me a bit, okay? All right. Okay, so we've mapped out Ernie's skin here. I can't stress how important it is to always mark your treatment zones. Do not do a treatment without mapping and marking. It's imperative. It keeps us in line with the treatment zones. It keeps us in line with how many lines we're delivering, but also it's a safety issue. All right. So I am going to actually grab the 3.0 here. And Ernie, I'm going to do it on this side, and I'm going to get you to turn your head a little bit for me to the left. Exactly. I'm going to place the cord like this. Can you guys see this okay? So when I spoke about the bringing that ship into the dock, so the hose is always to the toes. The reason why we want to do that is that we're working over the orbital rim, and when we deploy or release a treatment line, if we are hovering over the eye, we could end up in an adverse event. We don't want that. We want to make sure that we're always on the tissue before we send a treatment line, but we also want to make sure that, a reminder, the cord and the tip, when we look at the screen, the cord image is always on the left-hand side of the ultrasound screen, and the tip is on the right-hand side. When I first started, I actually put a little label here, putting cord and tip. Okay? Is it okay if I adjust this a little bit, just so I can see better? All right. So I'm going to put the ultrasound. Remember, we've got our, taking it out of standby into ready mode. We have our 3 treatment lines, or buttons to activate a treatment line. So I'm always going to work from away from me towards me. If you try to treat from this position and going lateral, I can guarantee you that you're not going to have good contact, and it's going to be more difficult to get a good image. So always start by bringing the transducer in like it's a ship coming into the dock. And if you watch the image on the screen, you'll actually see the frontalis muscle below the surface of the skin. Actually, Ernie, you could probably do a 4.5. This is good. So what I'm going to do is I'm actually going to ask one of my models here to just slip into the camera and hit the scan button for me. Thank you. Perfect. And what I want to have a look here is if everybody can see. Can you see this okay? Excellent. So as you can see, we've got I came in over Ernie's brow bone, and I see a little bit of the frontalis muscle below. I see the epidermis, subcutaneous tissue. I have a great amount of space here to work and treat Ernie with the 3.0. I want to make sure that I see that anatomy complete from left to right. So let's go back again. And we've got this psychedelic blue gel here. All right. Ernie, can you lift your eyebrows up for me, please? Perfect. So if we look at the image now, we can actually see on the left-hand side of the screen, we can see the orbital rim. If I keep sliding up a little bit more, you can see that I'm starting to get into the frontalis. I'm actually going to change the transducer here. Actually, I'm just going to make it a little bit brighter so that we can see it hopefully a little bit better, that you guys can see what I'm seeing. So I'm sliding in, bringing the ship into the dock. That's better. It's very bright now. So you can see the bone on the left-hand side of my screen, and you can see it going down a little bit. So if I keep sliding up, now it's level. So I am now starting to creep onto, I'm moving it onto the frontalis. See how it's kind of sloping back upwards? I am now on the frontalis. I'm still technically above the treatment area, above the bone, but if I treat here, I guarantee you that I'm going to hit the supraorbital nerve. So can you see that on the camera? Where I'm sitting on the forehead, I'm far away from the brow area, but if you look at the camera or the screen on the ultrasound, you can see that there is a bone from left to right, from cord to tip, but when I look at my treatment area, I'm clearly in the wrong space. So again, I cannot stress enough that we definitely want to work in this area right here, in this zone here only, between on that periorbital area. As soon as we slide up, we're guaranteed to hit those nerve branches that are coming from the supraorbital nerve, but also from the temporal nerve as well. That's going to make a difference between a good treatment, a comfortable treatment, and making sure that the client doesn't have an adverse event. Okay? Does that make sense for everybody? Any questions out there? So I'm coming in, again, the ship is coming into the dock. I'm going to see my orbital rim. You can see the top of it there just above the green treatment line. I'm going to go a little bit higher, and now I'm in a perfect treatment zone. Okay? I'm going to put the machine, the ultrasound into ready mode, and I'm going to deliver my first treatment line. What I want to do is I want to make sure that, Ernie, can you lift your eyebrows up? If he lifts up, he gives me a lot more space, and I'm still in my right treatment area. So if someone's complaining that it's a little bit, or concerned that it's a little bit too pricklier, it's a lot spicier than it was, say, on their mid-cheek or their submentum area, or they're a little bit more sensitive, the more we get them to raise their eyebrows, the more space that we get to be able to treat them more comfortably. It's all about comfort management. Sometimes even getting the patient to, listen to music. I know for myself, when I have my treatments, if I have my iPod playing or my iPhone playing in my ear, it kind of takes away from me concentrating on my treatment. So once I've done, I come back in, I get my position. Do I have another question? All right. So with that type of anatomy, you could definitely work with the 745, correct? All right, yes. Definitely, when I look at Ernie, we've got a lot more thickness and density of subcutaneous tissue. So definitely I would work with the 745 and the 3.0 and the 1.5, because I want to make sure that I get a good result. I have more than enough room to work with Ernie at those 3 depths, or I do the 745 and the 3.0 protocol. Good question. Okay. Now let's have a look at the anatomy on the crow's feet. So I am actually going to do the other side so you can see how I'm coming in on the treatment area. I'm going to just put a little bit of gel here, Ernie. Sorry, it's a little cold. How did that feel, by the way?
Fine, yeah. Okay.
On a 0 to 10, 10 being the worst.
Oh, it was 2 or 3.
Okay.
Yeah.
So some people have asked me, do you put, what if we put a 23% and 7 lidocaine topical numbing cream? Numbing cream will not help with Ulthera treatments because especially when we're working around the brow, the most important thing on comfort management here is really knowing your anatomy and knowing where we're treating and staying over the orbital rim. They're going to feel the heat. So when you're looking at doing anything topical, it's more for a treatment that is on the epidermis. We're working below the epidermis, and there's really not much that's going to take away from that. using the handheld Ulthera vibrator, getting the patient to hold squeezy balls, listening to music, just changing position a little bit, with their lifting their eyebrows up, just makes a whole world of difference. Okay, so I'm actually, I forgot to actually hit my treatment area. Me bad. Okay, so I am going to treat the lower part of the my treatment area. So I'm working away from the eye. So in this case, the energy is going to be traveling from the cord to the tip, but I never want it traveling towards the eye. So I'm going to come in this way. I'm going to basically, I like to rest my hand on the patient's forehead so that I'm steady-handed, that I'm not jiggling around. And then I have a look at the tissue. I want to make sure that I'm working around, it's almost like working around a daisy where, if the center of the petal is Ernie's eye, I want to make sure that my daisy petals are in the outside and I'm working around, okay? So if you look here, we have a good image. We've got some subcutaneous tissue. We've got just below the green line, the treatment line, you can see a little bit of the ostium or the muscle mass, but we're in a good position. So again, I'm going to come in here and look at my tissue, make sure I don't have any vessels in the area. Sometimes they will be there, and I will actually activate my treatment line and come around. How does that feel, Ernie? Sometimes if we, again, on patients who've got a smaller anatomy, a little bit smaller face, that temporal nerve may come into the mix. If it does, I'll ask the patient to tell me, when I describe it as a prickly, spicy heat below the surface of the skin. If it presents like a little bit of a traveler, that's a nerve. I'm touching on a nerve fiber. And if I hit it more than once or twice, I will actually adjust my treatment length. So my treatment length adjustment, we put it in standby. We've got our energy setting here and we've got our length. So what I'm going to do is I'm going to actually change my treatment line down to just a half to make sure that I'm not hitting that that area where the nerve fiber is kind of branching out. So again, I'm going to come in. You can see my treatment area now is on the screen, is only within the green area. Sometimes what we will do is if you work with the narrow, I know some clinics that have a high population of Asian patients, sometimes just buying and getting the narrow transducers will save you a lot of aggravation. But for those one-ofs that a patient comes in and you're just just triggering their nerve fiber a little bit, then you can shorten the line. But it's always probably a little bit better if you've got regular patients that are just more petite, then I would definitely invest in the narrow transducer. How's that feel, Ernie? Good. Excellent. Okay, so to recap, I will always work from the furthest away from me and work towards me so that I can always see where I'm going. I will never work by pushing away because I lose control. This way I can see exactly how my positioning of the transducer and where I'm going to treat. It also allows me to position myself so that the screen is always in my line of vision. The last thing we want is that device to be behind us. You want to position the machine on a left side or right side, depending on whatever you're most comfortable with. Okay. When treating around the crow's feet or lateral to the eye, we want to make sure that the energy is moving from the cord away from the eye. We want to mark out our no-fly zones. Now, let's talk a little bit about that area where a lot of women are, when I do a full brow, I work completely around the entire eye. I don't just do the brow. I will always include the crow's feet and just in that, just the tear trough area as well. Sorry. Thank you, Ernie. Ernie's keeping me on my anatomy here. All right. So I'm going to put a little bit of gel in the area. You don't want a lot, because once you put too much gel, you will get that ghosting, and then it becomes a problem, and you're constantly fighting with the ghosts. I'll position myself so I've got my elbows on the treatment bed. I'm going to look at my screen and make sure that I don't have, that's good. So if you look at the screen now, you can see that there is a little bit of the ostium below, sitting almost at the 4.5. Oh, I moved a little bit. There we go. So when I treat, I'm going to do my 5 lines straight down, and then I'm going to cross hatch my next 5 lines, and I'm going to go 5 lines this way. Sometimes the nose gets in the way. I will just tell the patient that I will be pushing a little bit on their nose, not to be worried or alarmed, and then I will actually cross hatch the last 5 lines in this area. If they present with a lot of fine lines and wrinkles, I will also do the 1.5 in this area, especially for women that got that crepey skin. But if men come in and they're a little bit heavier, I will just stick to the 3.0 and the 1.5 combined. Okay. So I'm going to do this one here. Ready, Ernie? Mm-hmm. So I'm going to go straight down. I'll come back and I'll cross hatch. So the center of my treatment area will actually get treated 3 times. And that tends to be in that tear trough area that most women have, or most of the anatomy kind of puckers in that area. So it will be treated the 3 times, and then you're going down laterally. Okay, so what I'm going to do now is I am actually going to change our model to our young female model, just so I can show you a little bit difference in the anatomy. So there are a couple questions that came in, so let's address those first. The first question that I have is the treatment good for festoons, and will it get rid of them? And if they have them already, should they just be treated over top of? So I think one of the big things with festoons or laxity in the area, anything will help. Again, it really depends on the varying or the degree of the festoons that a patient has. But when we look at the festoons, you can see even young women who've lost, they got a definite demarcation from the tear trough area into the cheek. You can actually start seeing that it's pulling away a bit. So the more we actually treat and build collagen and elastin, the better it's going to be. Is it an indication for festoons? No. But when you look at what we're doing with Ultherapy and we're treating the area, we are definitely creating new collagen in the tissue contraction. So anecdotally, people have reported that yes, they've seen some great results with treating these types of issues with the skin. Any kind of laxity, loss of collagen or elastin. Remember, it's not replenishing volume, but it's building that collagen, and you get that realignment of that DNA. So good question. The next question is, if the patient previously had tear troughs, fillers in their tear troughs, tear trough area, will you still treat this zone? Absolutely. Most people who have tear trough issues will have volume placed in. If they need, if they have laxity, I will definitely treat with the 1.5 and the 3.0. My preference is to treat them first and then do filler in that area. But if they had filler in the area over a few months ago or 3-4 months ago, if it's just been a month, I will get them to wait. But if it's been a few months, definitely I will treat the area with no concern whatsoever. So let's have a look here. I've wiped my transducer down already, but I'll just give it another wipe. So you can see here that we have a different, I'm going to get you to turn just a touch towards me. The hose to the toes or nose, and I'm going to come in, don't be worried, I'm pulling on your lid a little bit. You can see how close that bone is on the 3.0. So you can see I'm barely up over her orbital rim, and the orbital rim is a little bit above the 3.0 or the treatment line. I'm going to get you to lift your eyebrows up for me and see what happens there. So let them go again. So, all right, lift your eyebrows up again. And we are just below or just above the bone on the left-hand side of the screen. So drop down again. So if I treated like this, I would actually set the stage that she wouldn't like me much longer. So I want to make sure that when I start that from left to right, I can see the frontal or the orbital rim below my treatment line. Lift your eyebrows up, and I'm ready to go. So I'm going to get you to hold like that. There we go. And I can see the bone from left to right. Now let's say I slide up a little bit more, and you can see on the far right hand side the frontalis muscle is coming a little bit higher, and now I'm still below the treatment area is still above the bone, but I'm well into her frontalis area. Okay, so I just had another question come in. Okay, so this is a great question and a great comment. One of the things when treating with the 1.5, we can't stress enough the importance of having excellent contact with the skin. I'm actually going to switch my transducer to the 1.5 to show you what the image should look like. If you don't, with the 1.5, because it's treating more superficial, if you don't have good contact, those little TCPs will end up sitting on the epidermis, and you get these little bump-like dots, and the patient's not going to be happy. They do resolve, but it's really important to make it more comfortable, but also to make sure that that you're delivering the energy in the correct tissue. So let me just show you. Oops, I'm getting stuck here. So now you can see with our narrow transducer, we are actually sitting very superficially. And I have good contact, and you can see that my treatment line or my bone is well below my treatment line at the 1.5. And do you feel how much harder I'm pressing? So again, if I'm going a little too light, you're going to have a little bit more space on the top layer of the ultrasound. And if I press a little bit harder, I'm going to get a good contact. And you can see the bone from left to right. Okay. Now, this allows me to have a good treatment zone, and it keeps me really clear and concise over that orbital rim. Whereas when I'm working with the larger transducer, sometimes I do creep up. Can you turn a little bit more this way for me and lift your head up? No, just lift your, give a crunch there. You can see that there's not a lot of space between her lateral brow and her hairline. Guaranteed that we would hit, if we didn't have that transducer positioned correctly, we would definitely hit that nerve fiber. Okay? So you can see the difference in the anatomy. I don't think we'll see much difference in the crow's feet, but let's have a look in the thickness of the tissue. Let's put this here. So you see a lot of density there. We're good. And I would have absolutely no problem treating the area here. If we were treating the festoons with the narrow, again, if you're going to be doing a lot of brow lifts and treatment around the eyes, I would definitely invest in a 1.5. It makes life easier. You can do tons of treatment lines and not be hitting their nose, and it just gets us into that right space, and I can go over and over and over again and making sure that I'm cross-hatching as well. So working with the narrow transducer just makes life a lot easier for us technicians. Okay, good. Let's recap on a few things. Comfort management is going to be key with treating the brow area. Make sure that you're using your visualization, that you're choosing the right transducer for what you're visualizing on that patient, and make sure that, you know, have that conversation with the patient, have a discussion during treatment to understand if they're feeling that little heat spiciness or are they feeling that little nerve sensation. If they're feeling that, just readjust, change your treatment lines, the length of your treatment line, get them to lift their brow, and if you still can't find that sweet spot, then definitely change your transducer. The variations exist in the skin, so we want to make sure that we understand how the patient presents, you know, their overall morphology. You know, visualization is an approved indication for an amazing benefit that we have with Ultherapy, and use it. Use your visualization as your tool to a successful treatment and a comfortable treatment. Okay. We just got another, okay. So one of the key things, and I'm not sure if if you've had the opportunity to read the clinical study on the brow lift, but that was the first approval that Ulthera received, was the brow indication. And after the study, they did a multi-center study. After the study, they found that the brow lifted on an average of 2 millimeters post-treatment. So anybody who's complaining of a heavy brow, the hooding over their eyes, they're, you know, toying with the idea of doing surgery, sometimes doing a brow lift with Ultherapy is going to make them very happy and give them a little bit more longevity without having to go for a surgical indication. Patients who you're using a lot of Xeomin on that are trying to get more of a lift, sometimes doing a combination of the brow lift with Ultherapy and then following up with Xeomin injections, you know, 2 weeks post, 2 to 3 weeks post, will be a home run. As the Xeomin takes over the course of a month, 2 months, 3 months, 6 months, they start getting the lift from their brow. It's very subtle. Take great photos, before and after pictures. Patients do see it. The images that you see in our flip chart that we use for consultation, I personally see these results in my practice, and it is definitely something that I talk and I speak to everybody about when they come in for a consultation for anti-aging in the face. The big thing that I also like doing is combining it with our skincare. The Neocutis eye serum is definitely a great investment, especially when they've spent $1,500 for a brow lift. You know, using that growth factor will really help support that anti-aging in that tissue, most importantly, but also around the entire eye area. Remember the safety. Safety is key. Use your visualization. Make sure that you have your Ulthera device in sight when you're treating, so you actually are using your visualization at all times. that you treat over the brow area and that you're not creeping up into the frontalis area or the temporal area. Know that, post-treatment, they could have a little bit of erythema, they could have some swelling or edema. If they have those little treatment bumps, that's because we didn't have good contact on the skin. Make sure you have good contact. It is so important. It's more contact than the 730 or the 4.5. So it's hard to remember because we get into the mode of doing the full face and then we always leave the brow to last. Remember, when you pull out that 1.5, think about it, put a little bit more pressure onto the tissue to make sure that you're getting a good penetration of those little TCPs. The instruction for use, if you don't have your instruction for use manual, it should be in your practice. Have a read, go through it, review your consent forms, make sure that you review all of these little things with your patients before treatment and your post-care. All right. So at this time, I want to say thank you very much to Merz for inviting me back again to speak on part 2. Hopefully we'll have a part 3 in the next little while. We will have this on video on the website within the next 2 weeks. Your regional business managers or your field team will also let you know when it's up and running. But by all means, if you need more assistance with the brow lift, your ACE team are phenomenal. They know their stuff and they're more than happy to help you guys understand or get technique down to make sure that you're having safe, effective, and amazing results and a great ROI. Thanks again.